I have so many thoughts and ideas, but I want to get your feedback. But let me just start with something as I was thinking about where are we in thinking about sleep in kids with Lennox-Gastaut syndrome. We're way behind because this is a place where we could actually intervene and make a difference, right? As neurologists, we get to admire the problem a lot, and it's time to stop admiring and do something about it. If we think about people with trisomy 21, they're 20 years or more ahead of us on this. So the first question that I wanted to bring up for you guys, and then we'll kind of go from there, is can you tell us about just a tiny bit about state of sleep and evaluating sleep for people with trisomy 21? Maybe Gita, do you want to?
Sure, I can answer that. So as many of you know, it's standard of care to evaluate children with trisomy 21 for sleep-disordered breathing. Most children should get a sleep study by the age of 3. And part of the reason is that, we talked about how the questionnaires that were developed to assess sleep in typically developing children, they didn't do a great job of capturing sleep-disordered breathing in children with trisomy 21. Also, there are studies that show that parental report of having a sleep disorder or not having a sleep disorder were also inaccurate. So there were many people who thought their child had great sleep, but they didn't. There are people who thought their child had poor sleep. The sleep was okay. So those are a few of the reasons why there was a move to just screen everybody using the gold standard of a sleep study. And 2, the consequences of untreated sleep disorder breathing in children with trisomy 21 are really big. So making that effort to have that sleep study done no matter what paid huge dividends.
Yeah, so I think that the incidence of sleep disordered breathing is more than 50% in people with trisomy 21. And if you think about the developmental and behavioral consequences of untreated sleep apnea in those people, it's really important. So that was 20 years ago that they figured it out in that population. So here we are, let's move, right? Let me ask you another harder question. If you could design, forget about the dollars, let's pretend we have a money tree. If you could design a study today about sleep and people with LGS, what would you think about first?
I'll try. I think we're still at a place of a black box, trying to understand what are the true incidents of abnormalities that fall within the spectrum of Lennox-Gastaut syndrome. So it'd be great to, have like a broad battery to understand gold standard polysomnography in the patients who may reasonably tolerate such a study. Really being thorough with sleep diaries. And I think, interestingly, trying to use some of the key information that we get from some of these more well-established criteria, but at the same time, comparing those to some of the newer surrogates like peripheral arterial tonometry, some of these features that would be and actigraphy, things that can ostensibly measure sleep without the full array of EEG and nasal pressure thermistors and all these hard things that really take an entire night and a whole team to apply.
Yeah, I agree with Rob. Also, I think it would be important to understand what the potential outcomes could be. So similar theme to all of our talks where we're talking about exposure and outcomes. So what matters? Are we trying to reduce AHI, which is on average, the number of sleep disordered breathing related events over a total period of sleep time? Are we trying to get better quality sleep? Are we trying to feel better during the day? Are we trying to improve behaviors? So I think that would be important as well to figure out what outcomes we're looking for. Two, I guess one big thing that we kind of touched on but haven't talked about too much is would that change the types of medications that people use. A lot of people use anti-seizure meds in a strategic way to improve their child's sleep quality. How would that work? So I think to design a study to assess sleep in children with LGS, we'd want to know those things and really clarify what the exposures are, what potential interventions would be, and then what are the types of outcomes we're looking at. Most studies of sleep look at all-cause mortality or cardiovascular effects, but few study these other outcomes.
Thank you. And we have people who understand adults here too, so we'll just throw that out as you're thinking about what your questions are. I see questions. I see hands. Tracy, you get chair's prerogative here.
Well, I have a microphone, so
Yeah, exactly.
I was
That
down
too.
first. This is Tracy Dixon-Salazar with LGS Foundation. So I have two questions from our home audience
Great.
as well, but I did just have a question on the follow-up for the trisomy 21, the Down syndrome children. So we have a pretty big population of trisomy 21 kids that have evolved into LGS. And if they're 20 years ahead of us, is there a database that we could go back and look at some of the research studies for the trisomy 21 kids that have LGS? Like, where could we find that? And you don't have to answer it now, but like, where is that? And
That's a great question, Tracy, and I don't know the answer, but I bet you it's out there. We could,
Okay.
we should look at that. Yeah,
great. And
idea.
if I can just ask the home
Yes.
questions too, and then I'll give the mic to Pete here. So the first one's from one of our LGS moms, Ava. She's heard that melatonin can actually be a bad thing long term, and she wants to know the thoughts of the experts here, because we use it like it's kind of like it's candy in our community. It's quite excessive. So thoughts?
Thank you. You know what? I'm
I
going to
can
turn that
talk
to
to that.
Althea. Yeah, go ahead.
Oh, hi. So Dr. Beth Mallow here at Vanderbilt, she's looked at, done several studies now looking at the long-term effects of melatonin. And basically, her last study, I think, which was published right before COVID, so in 2019, looked at melatonin use up to 10 milligrams for 3 years. And what she looked at was before starting melatonin, those hormones in the gonadal axis. So ACTH, TSH, FSH, LH, all of those things that we possibly get concerned that melatonin is affecting. And she checked those levels. And then levels were checked periodically, but up to 3 years and up to 10 milligrams of melatonin. And those levels did not change. And this was great because it also looked at pre-pubertal children and children in puberty. So we had evidence before that melatonin in pre-pubertal children was likely safe, but we didn't know about kids undergoing puberty. And so this study looked at both pre-pubertal and kids going through puberty, and there were no adverse effects in that in those gonadal axis hormones. So that's what I can say about the safety of melatonin as far as research-based. What I do get concerned with melatonin is that it is over the counter and that often there's no regulation. And people will, just last week I had a parent come in and they were like, oh, we're giving our son 60 milligrams of melatonin. I was like, what? Like, who told you to do that? Nobody told them to do that. They decided that more was better. And so I often see this kind of, I don't know what the word is, but just probably not safe use of melatonin in children because it's not being supervised by a physician. And so that's my concern with melatonin.
Yeah, I would agree with that. I mean, I know that we have evidence that the incidence of overdoses and poisonings with melatonin has skyrocketed in the last several years. It's gone increased by more than 250%. We have general ideas about what is the appropriate dose as prescribed by physicians, but what families may get. And then, of course, because these are not FDA approved or regulated medications, there's lots of evidence suggesting that what you get in a particular bottle may not be the right dose, or there may be other contaminants within there, like clinically significant amounts of serotonin. So there are things that we have to be mindful of there.
Thank you.
Great, that's really, really helpful. And thank you, Althea, for your talk. That was fantastic, and the comments are great. So the second question is really directed at you, Robert. Sleep is strongly disrupted in LGS children in many ways, but there's a lot of this generalized paroxysmal fast activity that's happening in the thalamus, especially in the dorsal thalamus, as you start to uncover the neuroscience of LGS. And so Frank Sieg from New Zealand was asking about how that might be playing a role, in calming down the brain and generating sleep spindles. And is there something you can predict, because you guys here, and this is for everybody really, you understand the neurobiology of sleep. Where is GPFA fit into that?
That's such a good and hard question, and I think in my nascent career, I've learned that probably my smartest answer, but also my laziest answer, is that yes, we're talking about a network disorder. It's easy for us to think about, oh, there's a specific lesion in focal epilepsy, and that's the problem, and we get rid of that, things are better. But we know that children who have early developmental lesions can then progress to a Lennox-Gastaut phenotype, and that's a network. Even though there's something that was clearly focal, we've now developed a broad, generalized process, and absolutely the thalamus is involved. I think our contribution of the thalamus and hypothalamus in these patterns, yes, we're talking about a complex network disorder that, if one is perturbed, that's why we're seeing these challenges. But do I have any novel or good ideas about targeting one, other than what I think perhaps I'd be very curious to know as we're doing more things like DBS and RNS and thalamic targets, are we going to see sleep outcome data coming from that?
Great, thank you. Pete, I saw you have a microphone and you have your hand up, so I guess you win next.
So thanks for this session. This was really helpful. I'm an adult neurologist, and I run a program here at University of Maryland for adults with neurodevelopmental disorders. So I get the handoff from some really fabulous child neurologists, and so this is a huge challenge. I would say just about every other patient that I see has some issue with sleep. I would say among the most common ones are either delayed falling asleep, or the more dreaded going to sleep at 10 o'clock, waking up at 2, and then being awake from 2 to 4. And so one thing I have learned is to, as a doctor, is when I turn to the parent of an adult who's been doing this for 35 years and say, have you tried melatonin? I usually get gales of laughter. And so, because everybody has tried it. And so I'm just curious, what is your litmus for deciding when to move to a sleep study for these individuals? And the corollary question is it always a bad thing if someone's getting 5-6 hours of sleep if there's no evidence of excessive daytime somnolence? So as a practitioner, how much do I need to pursue a sleep disorder? I'm a neurologist. I've looked up parasomnias. It's not clear that going to bed at 10, waking up at 2, then being awake till 4 and going back to sleep is necessarily a parasomnia. So I'm just curious, how much do you do it? Because actually we put people often in the EMU and we don't actually see anything that looks like disruptive sleep patterns. So how do you guys approach that?
Such a good question. Who wants to take it?
I guess
Dr. Gupta.
I think I can start, but I'm sure. Oh, sorry. I didn't realize.
You can go ahead and start. Yeah.
All right, we'll do Gita and then Althea.
Delayed. The Zoom is a bit delayed. So I think I personally have a very low threshold to screen for low-hanging fruit. So what can I treat? What can I change? So sleep disordered breathing is something that's relatively easy to treat compared to many other sleep issues. So if you find sleep apnea, for example, especially in a child, and sometimes it's as easy as, I shouldn't say easy, but for some children, you can remove the adenoids and tonsils and treat their sleep disorder breathing and make a big difference in that child's life. I know the dreaded CPAP or BiPAP is an option, and it can be very helpful for some people. And it's something that has very tangible and effective results. So I personally have a very low threshold to screen. And then 2, there's a lot of subtle sleep apnea that's very hard to assess just based on visual inspection. And there's a lot of sleep apnea that can be missed. And so I think any symptom that's remotely suggestive of sleep apnea, I would screen for that using a sleep study. And then I think your second question was about the melatonin.
Is
Right.
is it a problem
But-
to be up from 2 to 4?
Right.
I would say the caregiver, it's a problem for them, right? But, right. Right, and the other issue being, getting up and walking around the house. I'm
I
going
would
to turn
say,
to...
though, just
Yeah, go
to
ahead.
finish that thought, though, it's not, sleep apnea doesn't just affect breathing, but it also leads to more instances of cortical arousal. So people with sleepwalking, other sleep-related behaviors will do those more if they're being woken up by the sleep apnea. The insomnia is so much worse if something is waking you up repeatedly in the middle of the night. It's those tiny little awakenings that can lead to the big obvious ones. So when I
Yes.
say treatment of the sleep disorder breathing, I guess I should have clarified that can be a reason that the brain is waking up repeatedly, but not clearly visible to the naked eye, and that's something that can be treated.
Great. Althea, did you want to add something?
Well, that's exactly what I was going to say. Whenever I have someone with sleep maintenance insomnia, even if I'm not getting like classic sleep disordered breathing symptoms like they snore like a train, especially patients with neurodevelopmental disorders, I get an overnight sleep study because just the sleep maintenance in itself can be a presentation of obstructive sleep apnea or sleep hypoventilation or sleep hypoxemia. And so that may be the cause. That may be what's waking them up in the middle of the night. And then once they're up, I always ask, what's waking them up? Is there an underlying sleep disorder waking them up? And then really what keeps them up then is their anxiety, they're doing their repetitive behaviors, their headbanging. So something else, may keep them up, but what's waking them up? So I do think I have a very low threshold to screen for sleep disordered breathing. And oftentimes just the presence of sleep maintenance insomnia makes me screen. Because also a lot of children with neurodevelopmental disorders, even if they don't have like severe hypotonia like patients with PWS, they still have some subtle hypotonia. And that subtle hypotonia makes their upper airway more collapsible and then makes them more prone to obstructive sleep apnea. Also, these children tend to have very small oral cavities, and even adults, small oral cavities, high arched palates, not a lot of room in their oral cavity, which also makes them prone for obstructive sleep apnea. So that's number one, so very low threshold. Number two, I do get concerned about the waking up at 2 and not going back to bed until 4, or the sleep disruption, because I get concerned with how is this affecting the endocrinology system, like the sleep endocrinology, which itself is very complicated, and I have to review in our sleep Krieger book every year. But is this affecting our thyroid levels or our thyroid function, which can then lead to overeating and obesity, which then can lead to something else. So I anecdotally find that it's better to have 6 hours of continuous sleep rather than 6 hours of broken sleep.
Thank you. We have a question over here.
Hi, Shauna Garris, Villanova, also a pharmacist, and so I have a question as such. Key takeaway for me today, I did not realize that melatonin was a substrate for CYP1A2. So then that brings me to, you talk about the complex relationship between sleep disorders and epilepsy, including insomnia. Do we know or have an idea of how much of this could be an interplay between melatonin metabolism and our enzyme-inducing ASMs?
Ooh, interesting question. I see Rob bringing the microphone up, so he dares to answer. Go for it.
No. It's a really fascinating question. I don't think we have that information, though. It could be done. Gita talked a little bit about like the process of learning about melatonin, like, how you can assess melatonin and do things like dim light melatonin onset levels and these types of things, and what are the influence of our ASMs on those types of levels, but I don't think we have that information.
Great. There was a question on the. There are several. I like it. All right, good.
Hi, Satish, Takeda Pharmaceuticals. First, thank you. This is near and dear to my heart, this sleep and epilepsy discussion. My question is to get your thoughts on using sleep EEG, not to look at sleep, but brain age. And the context is there was a white paper from ENSO data that looked at sleep EEG and predicted the person's age with a deep neural network. So I guess what I'm wondering is feedback on, do you think that could be a good, trial marker to look at biologic brain aging based on sleep EEG analysis? Yeah, that's the question. Thank you.
So I personally don't know that answer, and I'm also not a neurologist, but we do know that studies of sleep deprivation, say in rodents, leads to premature death and premature aging, and insufficient sleep leads to accelerated telomere shortening, for example. Disrupted sleep leads to increased telomere shortening, which is kind of a function of our body age, right, or cellular age. To disrupted or insufficient sleep leads to a whole host of outcomes, like poor brain health, cardiovascular health, endocrine health. So I don't know the answer to your specific question, but I don't see why not.
Sure, worth looking at. There's so many questions that I'm going to start pinging faster. Go.
Hi, I'm Susan Dando from the Smith-Kingsmore Syndrome Association, different Smith than Smith-McGuinness. Our population has probably around 50% with seizures, but around 90% with sleep disorders, which is why we work with Tracy on this sort of stuff. Just 2 comments. On melatonin, one of the reasons that we laugh when doctors ask us about it is we've often been told to give our kids melatonin without instructions as to the best way to do melatonin. So anecdotally, we're giving it too late. They get 3 hours of super sleep and wake up at 1 a.m. and destroy the house. So that's partly why, actually melatonin for us is a very double-edged sword within our community. One question I do have is around sleep studies and who's looking at them, because some of our folks do have sleep studies, and it's like, it's mild snoring, not a big issue. And so my question is, or a potential area for collaboration is, does it make a difference who's actually looking at the sleep study with a lens of, I'm looking at a sleep study of someone with a neurodevelopmental disorder, and might they be looking for different things than if a neurologist without a real sleep lens is looking at it? And could that be a way that potentially, if we share data, you might see different things in our sleep studies than our neurologist at CHOP or wherever who doesn't have a sleep lens?
Really good question. As a non-sleep doctor, what I would say is, yeah, right? That there are plenty of sleep medicine physicians who are frightened of our patients and our loved ones, and feel that they don't know quite what to do with. I know in Michigan there are just a handful of folks who will interpret the polysomnograms from people who have epilepsy because they want to be able to look at the EEG component more carefully than they normally would have to if it was somebody who never had a seizure. So absolutely, and I think part of the question for research would be, that's that central review, and that's the value of making sure that you have the right people looking to have a standard. But for clinical practice, the tricky thing is, child neurologists or even, adult epilepsy specialists are in, they're rare birds. Pediatric-focused sleep doctors, especially ones who are interested in people with neurodevelopmental disabilities, they're really, really rare birds. And so I don't want to stand here and say you have to go to the ultra specialist no matter what. But if we're not getting where we need to go, we need to develop more of those very rare birds so that we can collaborate with them.
Hi, Trisha Profrock. I'm one of the parent caregivers. And I don't have a question, but I was prompted to speak with the question that was posed, what's waking them up at night? I just wanted to add that for my son, among many other things, it's as simple as positioning. He doesn't have good control of his body, and so no matter how I put him to sleep, he's waking up upwards of 15 times a night to reposition his body because he will fall asleep in a pretzel position, and his feet will become a beautiful shade of indigo. So he is constantly having to reposition his body because maybe his feet are falling asleep, or so, his brain is waking him up to move himself, and he doesn't know how to get himself in a proper sleep position. So that's just something, and we've tried, hip spreaders to try to keep him from being able to cross and get into that, crisscross applesauce position. But for him, sometimes it's just as simple as improper positioning. So I just wanted to put that out there as a consideration as well.
Thank you so much. That's really, really important comment. Can we get a mic over here for? Great.
Hi, Enrique Carazana and Morales. I have a question. How do you guys think about the ASMs, given the sort of infinity number of combinations that patients with ALS are put on, and the positive and negative effect of all these drugs on the sleep architecture? How do you approach a patient, not just in the clinic, but also in research, how you deal with that variability?
Right, the infinite combination of medicines. And I would say not just our anti-seizure medicines, but all the other things that people are taking that can have an influence. As a clinician, I ask, right? When you adjust the dose on this medicine, what happens, right? And sometimes they'll say, oh, don't you dare adjust the dose of this, because now that we're taking, that med at this time, my child will go to sleep. And we're going to keep it that way, no matter what you say. Or, well, you can't move the dose of this drug closer to bedtime because I won't get them to go to sleep. And so, there are those balances. But teasing that out, so on a case-by-case basis, it's, tell me, parent or caregiver, what happens when we make those changes, or when you're late for doses, what goes on. From a research perspective, complicated, and right now it's more typically admiring this issue and recording what medicines are people taking, right? Because there just hasn't been enough sophisticated work from a sleep standpoint in this particular population to really get there. And I think the need for really large collaborations to start to even begin to tease that out is very clear. Does anyone else have a comment on that? If not, that's okay. Other question? Yes, Tracy.
I have a comment, and again, we don't have a signed contract, and I'm probably going to embarrass the heck out of Dr. Warren over there. Hi, Aaron. Aaron over there. He's our newest grantee, and he's going to be looking at sleep in patients that are being implanted with RNS. And so I feel like you all here need to, and him over there need to become best friends, and then we need to start a sleep work group together, because I think it's going to be really fascinating, because all of these questions that are being risen, the answer seems to be we don't know, we should look, right? And so you have a group of people here that want to look, so I'm very excited about this session. I can't thank all of you enough, and I'm looking at you too, Althea. Just because you're not here physically does not mean you have not been volunteered to help, so thank you.
There's 6.
So just to say that again, what Pete?
Yeah.
Oh, go ahead.
I just looked on PubMed, which is the National Library of Congress, so the papers that we use in science and medicine. I searched Lennox-Gastaut syndrome and obstructive sleep apnea, and there's 6 papers published on this. 6 in the world history of literature.
Right.
So we clearly have a lot of work to do.
So one day, hopefully not too long from now, we will look back and say, what is today's date? September 15th, 2023 is when we blew this whole thing open, right? This is the goal. And it's an exciting place. Jim?
So Jim Wheelis, so for the people that do sleep, if I'm developing a new therapy for Lennox-Gastaut, and well, the gold standard might be to do PSGs. We realized that, okay, one, a lot of the really bad LSG patients that are in trials, when I look at their EEGs, they don't even have, sleep staging. There's no sleep architecture, there's no sleep pattern, so I might not even be able to stage it. Two, behaviorally, they wouldn't tolerate it. The vast majority that are in the trials, these folks that are having, 800 seizures a month. So if you were advising me, and I said, I want to try and get a measure that will help me determine if my treatment is having a negative or positive effect on sleep that's actually meaningful, what would you tell me to do that's reasonable in a trial? Because, what I'm hearing is a lot of great research stuff, but nothing that I can apply to my patients.
Yeah.
I want to add. Go ahead.
Okay, I'll take this one and then let everyone else answer this question too. So that's part of my study that I proposed that you guys are going to be supporting, because I agree we don't know that answer, and yes, the PSG is great for most people, but for many groups of people it might not be, including people with LGS, because of exactly what you said. The sleep architecture, is that so helpful? Can we get the other remaining information using a home sleep apnea test, which is far few sensors? Can we use a wearable device? Can we do something else? So we don't know that answer yet. And there are other conditions too where a sleep study oftentimes underestimates or overestimates the sleep apnea, like a neuromuscular condition. So they may not have an issue with their EEG, but they'll have an issue with the effort belt and the other things, which we also use to detect apnea or hypopneas.
Yeah, I think trying to utilize the American Academy of Sleep Medicine's, very well put together book, and kind of same concept of using an inappropriate measure to try to apply to our populations, because yes, I think it really is trying to find better surrogates rather than asking how much non-REM stage 1 they have or stage 2, because that probably isn't an important thing or may not really exist in some of these patients. But looking at things like peripheral arterial tonometry as at least I can have a decent sense of patient is asleep based on heart rate variability, patient's now awake based on the actigraphy and all those information together, that's probably going to give us more information. Maybe there's quantitative EEG perspectives that are hiding underneath all the waveforms that we could also think of that aren't used on a clinical basis.
I guess the last thing I would add to that is, depends what question you're trying to answer, right? If you want to answer the question about does this person have sleep apnea, there's one set of approaches. If you want to answer the question about what's going on with the circadian rhythm, different set of approaches. If you want to answer the question about is anybody in this house getting any restorative sleep, another set of questions and approaches. So, the nice thing is we can frame the questions in a way that we can answer them today. And the hard thing is there's so many different questions to ask. And one of the things that I found so fascinating studying neonatal sleep is, like, every question I ask, we don't actually know the answer. And so I'm like, all right, well, then whatever we can come up with is going to be better than the complete unknown void that we have right now. Anybody else in the audience, or I'm going to ask my own question? Elaine.
So I'd like to ask so I have a number of kids, not just with LGS, but with other DEEs or significant developmental concerns. And a few of them have had clearly documented sleep apnea. And some of them have been candidates for tonsillectomy and adenoidectomy, but not always. The treatment with CPAP for those kids is very, very challenging. So even if you diagnose it and you try and use CPAP, in my experience, it's really not tolerated. And I wonder if any families here have also that experience. And do you have any suggestions? Because obviously it's an important issue and it's something we would like to fix, but the fix is not well tolerated.
Who wants to take that? Oh, I see Rob. Okay.
I can try. I mean, I trained at Children's Hospital of Philadelphia, and there was a sleep psychologist whose emphasis was CPAP training. Like, let's work on getting acclimated to the mask? How are you getting your child ready to use the mask? How are they just getting used to wearing the head straps, not even a mask on, just like put head straps on? How well will that child tolerate that? Can you get them to tolerate that? Can you then introduce them to wearing the mask while it's calm down time at night? You know, if there is such a time in the evening for some of these kids. But like, you know, it is just introducing the small little developmental steps, and can we introduce more and more and more? CPAP is hard. Bi-level is a little bit easier to tolerate, but insurance doesn't like covering it unless you really need it too, so that's another little challenge. Yeah, and then of course the additional nuances, like once you actually have a child who will tolerate going to sleep with the mask and the interface and everything else, they move over, they disconnect. Who's going to be awake to reconnect? That's another nuance of like, is it the parent? Is it going to be overnight nursing? Yeah, it's a hard situation.
I
Althea?
always tell my families that getting acclimated to CPAP is a marathon and not a sprint. And so we also have a sleep psychologist who I send many of my patients with neurodevelopmental disorders to help with acclimation to CPAP. And she's been very successful. But I always give the story of I had one patient with she actually does have she has Lennox-Gastaut, she has cerebral palsy, and it took us 3 years to get her to wear her CPAP. She would throw the CPAP at her mother, and I many times gave up on her wearing the CPAP, but I have to say her mother was this great champion for her and did not give up, even at the times when I thought, I don't know what I'm going to do. And so, you know, it took 3 years, but now I've been seeing her since she was 14. Now she's 25 and she loves her CPAP. But yes, it was 3 years before she wore it. And so she needed it. I was worried because she wasn't wearing it, but it just took continued trying. And I know that sounds forever when I say that because it's 3 years. That truly is a marathon. But it can happen and it will happen for a lot of kids if we just kind of keep trying to reintroduce it. And I don't know how the other panelists feel. I know that there's now the hypoglossal nerve stimulation is being used in children with Down syndrome. And this is an implantable device for patients with obstructive sleep apnea who've not tolerated CPAP. And so this is now being used in children with Down syndrome. And so my hope also is that maybe once we see the success in Down syndrome, that this will be a device that we can eventually use in our other children with neurodevelopmental disorders.
Yeah, just to add on, I feel like we're on the same brainwave because that was going to be part of my response too. And then I guess just to wrap that thought up, you know, it's not great to have to do extra surgeries, but oftentimes people with genetic disorders do have multi-site obstruction of their airway. And so getting that formally evaluated by ear, nose, and throat using a drug-induced sleep endoscopy can be very helpful. And so basically what happens is under the OR, the person is scoped and their entire upper airway is evaluated in conditions that approximate sleep. And there's still some questions about what, you know, exact anesthetic type approximates sleep, but in general that too can be sometimes effective, getting those obstructed sites surgically taken care of, and that can really reduce sometimes not the need for CPAP or BiPAP entirely, but it can really reduce the amount of pressure that child might need, so that too can make long-term CPAP or BiPAP use much more comfortable. The reality is many children, this is anecdotal, as you said, there are very few studies of LGS and OSA, but tend to need high pressures to keep all of those sites of obstruction open. So if we can even reduce the amount of pressure that's going through the mask, that too can be helpful.
Thank you.
Yeah, well, you may have answered some of my questions, but I was just thinking of everything that I'm hearing today, and I think of my own son who's 21, big dude, you know, he will not tolerate anything. I mean, we're lucky he can wear a helmet, and that's about it, but he's been wearing that since he was teeny tiny. So I worry sometimes, and we're going to have these discussions about the adults in one of the breakout sessions, but I worry that sometimes we kind of have given up on the bigger folks because he will not, I mean, we would not even be able to succeed in doing the sleep study because he would not tolerate that. We don't even do EEGs and so many other tests on him anymore because he just won't tolerate the tests. And then the CPAP, I myself also have sleep apnea. I didn't tolerate the CPAP, so I can't imagine what it would be like for him. So, I just worry that it's just, most of his seizures are nocturnal, and so how much of that is due to the snoring and probably he has sleep apnea. And I don't know, it's really more of a comment, I guess, because I don't know how you can respond to that, to those who will not tolerate. I mean, do you have behavior interventionists that are also on your teams?
So I'm just going to just jump in and say, I hear this a lot, right? We can't do, and maybe it's because we don't know all the tools and the ways and the state of the art because we haven't had our new best friends at the table to get to know that, right? And to be at the sleep meeting where you have the industry reps who are thinking about, and the bioengineers thinking about how do you make this better, and to raise to them the really important need that we in our community have, that we need their help and collaboration to solve, right? So this is, if we've identified that it's a problem, it's not good enough to say it's a problem and we can't fix it, when we know that for other patient populations, they've found ways to fix it and it makes a big difference. So this is, we can do the hard things. It's going to be hard work, and this is a marathon, but we need to show up in the places where our potential new best friends can solve our issues.
Hi, I'm Tracy Dixon-Salazar with the LGS Foundation. I just want to add one more life hack to the toolbox for some of the people who are treating, and this will not work for Theo, Jen's son, and it will not work for Mason, but we have one family whose son does wear his CPAP because he looks like Tom Cruise in Top Gun, right? And I link that back to my own daughter who just recently had to start wearing her seizure helmet again and her drop harness, and she didn't want to, and she's very motivated by boys, so we got a bunch of boys to record videos telling her to wear it, and now she wears it no problem and takes her meds. And so sometimes finding the thing that really motivates, and again, this will not work for Theo, this will not work for Mason, but it's just another life hack that we've found in our community that might help for this audience people.
Thank you. One last question, then we'll wrap up.
My name's Mary Wojnarowski. I'm a psychologist at Nationwide Children's Hospital, and we have also a large autism treatment program and assessment program for kids with neurodevelopmental disabilities as well. And there are psychologists who do help kids with neurodevelopmental disabilities wear their CPAP, just like was mentioned earlier. It does sometimes take a very long time, but kids can be successful. Most kids can be successful with that. We also have a program where we're helping support kids with autism who are admitted to the EMU for a week-long EEG, and that's actually been remarkably successful with some practice, desensitization, reward. Kids can do really well. Obviously, it may not be effective for every child, but I think there's a lot of supports that can help kids who we say, oh, well, they're not going to tolerate it. But with some support, they may actually be able to do it. So I don't know. I've been really excited about that work. And I guess I just want to say that there are strategies and things that can be helpful, that can help some kids to complete the tests and then to wear their devices that will be helpful for them.
Thank you.
Can I say one thing?
Yes, please.
Yes, I to the lady before with the discussion of our adults, I hear you. We are not doing as well with our adult population with neurodevelopmental disorders. I feel like there should be a similar child life services for these adults in when they're in the adult side on the adult hospital, or something to help like we have for our kids. And so we do need to do better to figure out how we can help our adult patients who are having sensory difficulties, difficulties tolerating tests that they need, like we have on the pediatric side. I think I think the main issue is we haven't really finessed the pediatric side yet. And I think once we get there, we can then maybe subsequently or even concurrently improve our care for adults with neurodevelopmental disorders. But I do hear you, and I know that it's hard and sometimes painful.
Thank you. Can you join me in thanking these 3 wonderful new best friends to LGS? I know I've learned a lot from them, and I feel really motivated and empowered to keep moving this whole field forward. This is a place where we can make radical change. Let's do it.